Welcome to TPMG Health Talk. Join us for valuable insights and practical advice on health topics that matter to you most, delivered by our top medical professionals. At Tidewater Physicians Multi-Specialty Group, we're dedicated to providing high-quality, physician-directed care to the Hampton Roads community. Subscribe now and visit mytpmg.com for more resources. Now let's dive into today's episode. On today's episode of TPMG Health Talk, we're joined by Dr. Jason Browder, a board-certified physician in internal medicine with special interest in osteopathic manual medicine and regenerative medicine. Dr. Browder has been with TPMG since 2009 and is also an associate professor at Edward Vias School of Osteopathic Medicine. He is an author of Clinical Cannabis, a medical practitioner's concise handbook to applications of marijuana and CBD. With extensive experience in treating chronic conditions, today he'll share his insights into medical cannabis and its role in modern healthcare. Thank you for joining us, Dr. Browder.
Very happy to do this.
To kick things off, there's a lot of confusion and misconceptions surrounding medical cannabis. Dr. Browder, in your experience, what would you say are the most common misconceptions, both among patients and healthcare providers?
Some misconceptions about medical marijuana or cannabis or hemp or CBD, because people don't know what any of that is. And right, so I guess to start, the government has made designators on what is the difference between hemp and marijuana. And they basically just classified the difference between the two as, a cannabis plant. And if it has greater than 0.3% THC, it's designated and called marijuana. If it's less than or equal to 0.3% THC, then it's called hemp. And that's really the only difference. So the plants could look identical, but when they measure the content of the flower, if it has those cutoffs above 0.3%, it's called marijuana, and less than that, it's called hemp. And THC is the thing that really is the designated separator between the two. So, THC and CBD are just cannabinoids. There's over 100 cannabinoids in hemp or marijuana plants. And, those are just two of them. CBD is the thing that everyone associates with hemp. It was first legalized in Virginia in 2017, and now it's federally legalized, I think, since December of 2021. And, the primary thing that CBD is known for is its anti-inflammatory properties, right? It's also the thing that is believed to benefit patients with epilepsy and strains of hemp, like Charlotte's Web, for instance. Whereas THC is the, cannabinoid. It's short for tetrahydrocannabinoid, right? Tetrahydrocannabinoid. And, there's different flavors of this. There's Delta 9, there's Delta 10, there's Delta 8. But this is typically what's associated with the euphoric feeling that people get when they ingest marijuana, whether they smoke it or eat an edible, the high that they get from that. And so, I think of them as kind of CBD is the thing that we get from hemp because it's primarily, derived from hemp. And THC is primarily derived from marijuana plants. And it's associated with what we want for the medical benefit is probably the best way to say it.
Right. How has the medical cannabis field evolved over the years from a clinical perspective and in terms of legal acceptance?
Sure. So, people always credit California with the first state legalizing marijuana, that or Colorado, and it's actually Washington State was the first state. So I think that was like 2011 or 2012. In Virginia, marijuana became legalized, I believe, in July of 2022. CBD was legalized in 2017. And so it's a very interesting progression to watch it all as it unfolded. My story, at least with regard to this, is in 2017, the state of Virginia sent out a flyer saying, if you're a medical provider that prescribes opioids, right, we're going to have you follow strict guidelines to opioid prescribing. But they said, if you do not follow these guidelines, then you run the risk of not only losing your medical license, but we might put you in jail. And so, when faced with that, it was kind of irritating to me. I have a osteopathic practice where probably half the patients I have are musculoskeletal in nature. I deal with a lot of chronic pain. I had patients on opioids, and we were prescribing them, according to what we thought was the best practices, and along came the state and they kind of shook everything up. So they shortly thereafter legalized CBD. And I said, well, if I don't want to prescribe opioids and have to jump through all these hoops, they're going to have me and risk going to jail, right? Because I'm not going to do well in jail, right? The audience can't see me, but if you look at my picture, I'm not going to do well, right? And so I started looking to other alternatives other than opioids, right? To kind of determine, is this an appropriate thing to treat my patients? Is it efficacious, right? Is it going to work? And if so, what's the safety of it? And so I started down the CBD path, right? And if you look at it, like CBD, it's listed for hundreds of benefits, right? And I remember going to a market in Colorado in probably 2018, and they had this banner and it said, "What is CBD good for?" And they had about 100 things, and I was sitting there going, "Then it's probably really not good for anything." Right. So I started doing research into CBD, long story short, right? And then shortly thereafter, the state of Virginia legalized THCA, which is the acid form of THC. And people don't even know what that is. Half of the THC in the flower of marijuana plants is in the THCA form, right? And so they legalized that. I don't think that the legislators actually knew what they were legalizing at the time, because they legalized it, but yet they didn't want to legalize marijuana. Well, if you heat THCA, right? So you put it in an oven, right? Or if you smoke it, right? It decarboxylates, it loses the acid, and it becomes THC instantaneously. So if you heat the marijuana flower in the oven, half of that THCA will become an active form. And that's why people will heat it in the oven, is to get the extra 50% THC out of the flower that they can. Again, smoking it, does that instantaneously. So it went from CBD in 2017 to about 2019 to THCA. And then later on, about 21 or 22, they legalized medicinal marijuana. But the catch is you could only get that from the dispensary, right? It wasn't legal to sell. You couldn't barter it. You couldn't get seeds. You couldn't get cuttings or grow it on your own. Well, then the subsequent July, I believe it's July 2021, they said it is recreationally legal to the public and you can own 4 plants. And that's specifically laws in Virginia. So, again, from 2017 on, it went CBD to THCA to legalizing medical marijuana to recreational. And that's kind of like the transition. So along that route of that, I had an opportunity to work with my patients, try some of these things on them and get feedback from them, right? It also forced me to kind of read on these things. Initially, Virginia had required all providers who wanted to prescribe either CBD or THCA, you had to get a license for it. And when you'd apply for the license, they had like a little caveat at the bottom of it. And it said, education regarding this topic is dependent upon the provider, and we will not be providing any of it. So basically, they didn't require us to do any special education or CME or training to be able to prescribe marijuana. And so I took it upon myself to educate myself. And I realized, after talking with patients and other providers, even other providers prescribing it, they don't know what they're doing with this. And so that's why I wrote this book.
One of the central themes in your book is safe dosing. And what are the most...
Safety in general.
Safety in general, exactly. What are the most common mistakes patients make with dosing?
So we'll get to the dosing in a second, but the most common mistake that people make that are using marijuana either recreationally or medically is they don't know the source from which their product is coming. And that's a real problem, right? If you can see your neighbors growing it next door and they're giving it to you, fine. If you're getting it from a dispensary, fine. If you're getting it mailed to you, if you're getting it from a guy off the street, you don't know what the product is, right? And so all it takes is you getting, a product laced with fentanyl or spice or, cocaine, and you could have quite a bit of problems depending on who you are. So, I say to the patients and anyone who's using it, the number one rule is know the source from which your product is coming, right? When we talk about alcohol, for instance, one of the main reasons that we regulate alcohol is because the initial distillate that comes off of a still is methanol, which is toxic to humans. And if you don't discard that, you can have a heart attack. It can cause blindness. And so one of the big reasons it's regulated is for safety, which is the same reason that I feel that marijuana should be regulated and sold out of stores rather than bought off the streets, is really just for public safety. There's about 40 states, the last time I checked, that are either recreationally or medically or both legal. It's much like gay marriage, right? It's going to be legal in some states and it's going to make its way across the country and eventually get legalized just like that. I mean, it's the best analogy I can come up with. And it appears like it is. And so what Congress is basically going to do is when all 50 states have legalized it, they're going to say, oh, look, we're going to legalize it and it's federally legal now, right? The thing that, in my opinion, that's holding up legalization federally is that marijuana is classified as Schedule 1, which means that it has no medical use. This is according to that classification, not according to me. No medical use and a high abuse potential. Contrast that with cocaine. It's Schedule 2, which means medical use, high addictive potential. Because people will use cocaine intranasally for, say, nose fractures and stuff for anesthesia, right? And so it's odd that marijuana has a higher level of control and schedule. So for it to get legalized, in my opinion, the classification is going to have to change to medical use. Even if it does have a high abuse potential, according to what legislators think, they're going to have to reclassify it, in my opinion, for it to become federally legal. That's the holdup. And then there's a lot of stigma about it. I feel like I'm constantly fighting that with patients, right? They think of it like alcohol, and they, depending on their age.
Worse. I think people think it's worse.
They certainly do, right? If you grew up in my parents' era, they're watching, videos in school like Reefer Madness and all the bad things that can happen from using marijuana. And, a whole generation of people is scared of this thing because they're not educated about it, right? Mm-hmm. When it finally does get federally legalized, or if it, becomes available to sell in Virginia recreationally, in my opinion, the biggest problem we're going to have as a state is educating the population on what it is, safe use. That is really going to be the biggest hurdle. I grew up in Virginia, mm-hmm. and I remember in 8th grade, they were teaching us about alcohol and saying, oh, if you drink one drink, it's a shot.
The DARE program.
Yeah, and they would say, look, if it's a shot, if it's a glass of wine, or if it's a beer, it'll take about an hour to metabolize. I remember this. And I remember sitting there in 8th grade, and I'm like, why the hell are they teaching me about alcohol? I'm in 8th grade. I don't drink alcohol, right? But I guess other people were. And what they were trying to do was head it off and say, look, when you encounter this, know how to deal with it. And I still remember those classes and our health teacher teaching it to us. There's no education program in schools, in private schools, that I'm aware of. My kids are 16 and 18, and I was asking them, and I was writing this, did you guys get any education in school on this? And they said, oh yeah, they mentioned it briefly. I said, they didn't talk to you about the uses, overuses, lacing of the product. They said, I have no idea what you're talking about. So there is a lack of education about this in the community, in schools, and that's the biggest hurdle we find, right? When states legalize marijuana, right, there is an influx or uptick in ER visits associated with potential overdoses or concerns or adverse reactions that people have. Could that all be avoided with education? I think so. Right?
Absolutely.
Because people will use marijuana and they'll have bad side effects and they think they're going to die. And you got to tell them, hey, look, you're going to feel bad, but you're not going to die from this. There's 2 main strains of marijuana, that or hemp. I'll just say cannabis in general, sativa and indica, right? And indica is associated with the feeling of sedation and the high that people are used to. And when I tell people, say, I don't understand the difference, I said, think about it like tomatoes. We have like VS 100s and Big Boys and Celebrity. We have different types of tomatoes, and inherently they have different properties. You can see by the way they look, the way they taste, right? And the same is with indica and sativa, right? Indica is from the Kashmir region of India, right? That is where it's primarily discovered and grown. Sativa is primarily from South America, and they have different properties based on their different cannabinoids, right? And indica causes people to feel sleepy and have more of a euphoric high. Sativa tends to give people more of energy. And in that, depending on how you react to it and the dose you get, you can have some anxiety and paranoia associated with it. So a naive user of cannabis products, right, if they ingest somewhere around 5 milligrams of a sativa heavy product, they have a 40% chance of having a panic attack or severe anxiety associated with this. So if you've ever had that friend that said, I'll never smoke pot again, the last time I did, I spent, the night under my bed thinking the police were going to come arrest me, right?
Yeah.
I've heard that a million times. They probably smoked a little bit too much sativa. The thing is they feel like they're going to die many times, and they're not going to die from that, right? The doses that you have to smoke and harm yourself is somewhere in excess of 8,000 milligrams.
Wow.
Right? The average joint has about 8 milligrams.
Mm-hmm.
So you may feel like you're going to die, but if you have a good non-tainted product, right, you just need to ride it out. right? Not go to the ER. And that's where the whole education thing comes in.
Absolutely.
And so for the dosing, right, to your point, I generally will have people start on a dose, and I prefer them using edibles, and it's somewhere in the neighborhood of like 2.5 milligrams every 8 to 12 hours. So that's generally what works pretty well for them.
What medical conditions do you see as the most effective candidates for cannabis treatments? And are there any surprising or lesser known uses?
So, if you get on the internet, you're going to see hundreds of uses, just like you did for CBD for marijuana, because we're shifting away from CBD and talking about marijuana now, right? And so you'll see hundreds of uses. They'll say PTSD, depression, anxiety, tons of different diagnoses, and the research that I did for this book, I went through documents that are 400, 500 pages and multiple. I think I have almost 50 references in my book, and looking to find out what are absolute proven indications for this. And so there's about 5 that I found that I can concretely say, yes, these are uses, right? So insomnia, that's probably the number 1 cause that I prescribe. Chronic pain, right? That would be number 2. There's obviously palliative care. You're dying and you need something for pain relief. Very good option. Non-constipating, helps with pain, right? Spasticity, right? Muscle spasms associated with multiple sclerosis, right? I'll have patients come in and see me sometimes that were prescribed medical marijuana by other providers, right? Either for phone, or maybe they're coming to see me for manipulation and they happen to be using it. And I'll see that they're prescribed it for anxiety, depression, and different things like that. I don't find any indications for those things. And I really try to stick to my list of, these are the things that are indicated and these are the proven, and that is why I prescribe them. But I have people coming in saying, I have glaucoma, I'd like this, I have anxiety and depression, I'd like to have this prescribed for me, and I tell them no. It's not indicated for those reasons. And some of them are quite irritated with me, but if you're having anxiety and depression, there are medications that work better than that. Glaucoma, right? There are medications that work better than medical marijuana. For depression, people that use daily for about 8 to 9 weeks, somewhere around that point, they can actually heighten their depression. And so if someone has depression and they're treated for it, and I'm going to give them something for insomnia, for example, I'll tell them, you need to watch and see if your symptoms start getting worse for your anxiety and depression. As this, somewhere around 8 to 9 weeks, if you're feeling worse, it may be the medical marijuana causing it. And again, educating the patients to that, right? That's why I don't just write it willy-nilly for people and say, go on out and do what you want. I give them very specific things, products to buy when they go in the dispensaries.
What are the key contradictions or drug interactions that clinicians need to be mindful of when prescribing cannabis, especially in patients with multiple health conditions?
The main thing is in the book I have an appendix, and there's 3 liver enzymes that metabolize THC and CBD, 3 for THC and 2 for CBD. And, it's the CYP 450 enzymes. There's like 2B, CYP 2B, 19B, and then 3A4. So those enzymes metabolize all sorts of different things. And what I encourage a prescriber to do is look at the patient's medication list like you're supposed to when they come in, and then look to see if any of those medicines are concomitantly metabolized by those 3 enzymes, right? If their medicines are metabolized by it, if the marijuana's, it's going to potentially slow the metabolism of the marijuana and make it persist longer, right? Or feel like it's a higher dose. Sometimes the enzymes actually will cause more rapid metabolism of the THC, and then the patient is like, this isn't working at all. And that's because the other drugs are speeding up this metabolism. So, the providers just need to look those up, those 3 enzymes. And I have a list in the back of the book of the most common ones. You look it up and see which ones. But the interesting thing is, right, after testing, I'll have patients come in and I'll test their liver enzymes, and I'll have them go on the product, and I'll check it in a month and see what happens. I think the doses that we use are so low that it doesn't really affect it. Right? I think you'd have to go to much, much higher dosing for it to affect the metabolism of other drugs or even the marijuana. I think people need to stop think of it separate and not think of it as recreational, and think of it, these are the indications, right? So a patient comes in and says, I'm having problems sleeping. And I go, well, let me see here. After we get through all the things like what we call sleep hygiene, and that doesn't mean you go to bed dirty. That means you need to take a shower before you go to bed. It's like, is it a dark room? Are you watching TV? And once you've kind of established that they're not doing any of that stuff. And if they're having problems sleeping because they work third shift, name your reason, right? And you determine that they need some sleep aid. You start offering them over the counter, Unisom, Benadryl, which is the active ingredient like Tylenol PM and Aleve PM, right? And then you might want to go to medications, right? Lunesta, Ambien, Trazodone. Those are the ones that most people reach for. I tend to go right to, after, if they don't want to be on Unisom or Benadryl, right, which are easy to get over the counter, I tend to go and prefer medical marijuana, especially the edibles. And so I will tell them, look, you want to use an edible for this. You don't want to use a smokable, right? And by smokable, I mean if you're ingesting the product by smoking it, either through a vape, a bong, name your method, right? You want to use an edible. And the reason is the smokables last about 2 to 4 hours, right? And if you're trying to stay asleep all night, are you going to wake up in 4 hours and smoke again? I know people that do it, right? Right? So the wake and bakers, right? But if you do an edible, the duration is about 8 to 12 hours. This is clinically indicated for you. I'm going to get you a nice low dose of this. The time to onset's 30 minutes to 2 hours, but generally about 30 minutes to an hour. And you want to get indica heavy for insomnia. The edibles in Virginia are 10 milligrams. And I have them cut them into quarters to start and say, start with 2.5 milligrams. That way I know they're not going to have a panic attack. They're not even going to come close to overdosing. And then even if they accidentally overdose themselves, right? They say, well, this crap isn't working. It's an hour. I'm going to take a second dose. And then it all kicks in at once. And it's like 5 milligrams kicking in at once. Generally, they don't feel terrible. They just realize I'm a little bit higher than I wanted to be.
And it's nice because the edible doesn't give you drowsiness the next day.
Yeah, no. So what you're describing is the hangover effect, right? That we get from like Benadryl or whatever. People wake up in the morning and they'll
awful.
say, it is awful.
Yeah.
I've had to take it in the past when I have insomnia, and you wake up and you're like, I can't get going. It's like 7 in the morning. It's like 10. You're like, man, I'm finally starting to feel like I can get going. There's none of that with edibles, as reported to me by my patients. You know, when I've used edibles for sleep, right? Because I'll use edibles for sleep, right? Full disclosure that I don't get that effect.
Well, as we mentioned the stigma earlier that surrounds cannabis use, how can healthcare providers help patients feel more comfortable discussing this treatment option openly?
I think just talking about it like it has validity, and then educating themselves. I'll say this, I'm a primary care doctor, right? That happens to do other things like prescribe medical marijuana, osteopathic manipulation, regenerative injections, right? I get referrals from other primary care doctors to prescribe for their patients for chronic pain and insomnia, you name it, right? All they have to do is really just take some time and educate themselves, and then, you know, gain a little comfort in doing it, right? The safety itself of the products and the dose needed to potentially kill yourself is so high that itself should kind of reassure them that they can do it. Maybe people are fearful for their license. But here's an interesting fact, right? I told you early on they made us apply for a special license and everything. If you have a license in Virginia to practice medicine or, you know, to care for patients like nurse practitioner, PA, you don't need a special license to prescribe medical marijuana anymore. It's implied in your regular medical license, and you can write it without any special designator anymore.
What are some tips for someone who's considering medical cannabis for the first time but is uncertain how to start?
I mean, you could read the book I wrote. The thing is there's a lot of medical jargon. I really tried to simplify it, though, and I think most people, as long as they understand what a half-life is, they can understand it. And so I think it's more like educating yourself and saying, what are the things for which it's proven to work? What are the things for which it's not, or it's unsafe, right? And then kind of doing like that. You know, if you have a history of schizophrenia or bipolar disorder, this is not the product you want to be using, in my opinion. And so when people ask me and they say, oh, will you sign my book? And I'm like, all right, fine, I'll sign it, right? I always put this, I put stay in the guardrails. And I'm sure they have no freaking clue what that means. Well, here's what it means, right? There are some things that you can do to really harm yourself with marijuana. And if you stay away from these things, you will be just fine, right? If you have mental health problems like anxiety, depression, bipolar, schizophrenia, you have to be very careful with it, especially about the latter, the bipolar and schizophrenia, right? You have to be very careful. That's probably one of the guardrails. One of the others is staying below a total daily dose of 30 milligrams, right? I put in the book 28 to 32, but 30 is a nice, easy number to remember, right? And again, the average edible in Virginia is 10 milligrams. It's going to last 8 to 12 hours. So it's not hard to stay below that. And then I tell people not to use high potency products. And by that, I don't mean a vape, right? Because that's 70% THC. I mean stuff like dabbing, and I mean like hashish. And, you know, for the people that don't know what dabbing is, if you think of an apparatus like a bong, and instead of having like a little bowl with a screen on it that you put flour in, there's a glass bowl in place of that. It's the same device with water, right? And what it is a water filtration, so that when people draw through the device, the gas that they're creating goes through water and cools, right? And the water kind of serves as a filter to take out particulate. Well, if you do this with dabbing, what you're doing is you're putting wax in that hot bowl, and it's instantly vaporized, and you inhale it all at once. And I think it was estimated that it's like 20 milligrams of THC all at once. I've had people with even single use of this become schizophrenic. There are people that have genetics with a predilection for schizophrenia, for example, right? I have those genes in my family. It's something that my family members would want to avoid doing for sure, because, you know, if you have a brain injury from smoking this stuff, you may not come back. If you stay in the guardrails, right? Avoid the dabbing, avoid over 30, avoid it if you have schizophrenia or bipolar disorder. I think that you'll probably do just fine, right? Whether using it recreationally or medically. But, stay in the guardrails. Should I make a bumper sticker out of that?
It sounds good. It sounds catchy.
Should I tell the governor that should be our slogan? I think the thing you can take home with this is if you stay in the guardrails and you're using it, right? Even if you have bad effects, right? And the products doesn't have fentanyl and all this, I'm put in these disclaimers, right? Even if you use it at excessive doses, right? You just got to ride it out and you'll be fine, right? And there's no need to go spend $1,000 at the ER for the ER doctors and the staff to all laugh at you and say, yeah, they're just high as hell again. And then send you on your way. And then you got $1,000 ER bill. So again, back to the education thing.
So one thing in your book, you mentioned drug testing, and it's probably something that a lot of people ask about.
Because again, we don't use it for our company because it's legal in Virginia. But, let's suppose that you go on vacation to Jamaica, right? And you decide to smoke a little bit recreationally, and you're like getting paranoid because you're like, oh my gosh, I smoked. Am I going to be positive when I go back, or if they test me, right? If you, with one use, you're going to be positive for 3 to 5 days. And if people want to put that to the test, you can actually buy off of Amazon home urine drug screening tests. You can buy them at the pharmacy. I've seen them there. And you can do your own piss test at home. If you have low body fat, then it doesn't store as long, right? But if you take someone who's obese and they smoke daily, it'll stay up to 30 days, right? So kind of having an idea of that is important. It's important for me as a provider, right, to understand this. Johns Hopkins did an experiment, and I don't know why I've never been involved in these experiments, but or designing these things. But they basically did a hot box experiment, right? Do you know what hot boxing is?
Yeah, I want to do that too. What? What experiment? How do you find out about these?
Well, I was researching, right? So I wanted to find stuff for drug screening. And so one of the questions that always comes up is, if I'm in the room with someone smoking, I'll be positive, right? And I get these patients that come in and they go, I was in the room with someone, that's why I'm positive on my urine drug screen. And I would say, I don't really know. So, well, Johns Hopkins put it to the test. And basically what they had was they had a test where they had kind of 3 arms, right? They had one arm that was smoking, I think 6% THC marijuana in an unventilated room. They had another arm that was 12% in an unventilated room. And then they had 12% in a ventilated room that was like air conditioned. And the air conditioner was ventilating the room, right? And they had this sealed glass room, and you could look in, right? And in the room, there are 6 people smoking marijuana, and there are 6 people sitting there breathing the air. And what they were doing was measuring urine, saliva, and blood to see if they were going to turn positive, right? And so the interesting thing of all that, right, is none of the, we'll call them secondhand smoke participants, right, the non-smokers, none of them were positive at 6% in the non-ventilated room. And none of them were positive in the 12% when it was ventilated, right? So no one at 6% low dose and no one at the higher dose when there's ventilation. But in the higher dose, right, without the ventilation, one of the people was positive, one of the secondhand smoke, one of the 6. The interesting thing of that is it was rapidly metabolized and they were not positive after 2 hours, right? So if I'm writing legislation and I'm trying to figure out who are these people on the street that are smoking, right? And I pull someone over and I think they're intoxicated, and let's just say they eventually do saliva testing for this, which is what I think they should do.
Yeah,
right?
it's cheaper too, right?
Well, you can't pull your pants down and pee on the side of the road, right?
Yeah.
That's not going to work very well, right? And they're not going to let cops stick people for blood. So saliva testing is probably the most viable thing, right? So if the saliva test is positive, right, after about 2 or 3 hours, if you retest, it should be negative if it's secondhand. So when someone tells me, like if my kid comes home and he looks stoned to me and I say, oh, were you smoking pot? You're underage. And by the way, this has not happened, right? Right. In full disclosure, he's a model kid, right?
He's like hearing this, what?
So if he came home and said, oh, I was in the room and people were smoking, I'm like, okay, well, we'll test you 3 hours from now. And if you're positive, I know you're lying to me. And if you're negative, then I know that you're telling the truth. Right. And I can garner a look on his face and figure out, well, he's telling the truth without even testing him at this point. But it's just interesting things like that I think are important for providers to know, maybe parents to know, so that, a lot of these things that people think they know and they don't actually know, you can apply, medically or at home, etc.
Check out Dr. Browder's book, Clinical Cannabis. It's an excellent resource packed with scientific tables, fascinating details, a wealth of research. Get educated. Stay in the guardrails.
Right. Know your product.
Know your product. Stay in the guardrails. Thank you, Dr. Browder, for sharing your insights with us today and your expertise. It's been a super exciting topic, one of my favorites. I will own that. So thank you. And thank you to our audience for joining us to TPMG Health Talk. For more information or to ask any questions, visit mytpmg.com. Stay tuned for our next episode. Take care.
The information shared on today's podcast is not intended to be medical advice, nor is it meant to replace a professional consultation with a healthcare provider. The opinions expressed in this podcast do not necessarily reflect those of TPMG or its providers and physicians.